Good evening, everyone. I hope everyone can hear and see us. You will see on your screen there is a chat and a questions block. Please, if you've got any chats, any questions, or you can't hear us clearly, use those two buttons to communicate with us. I would like to welcome everybody to this platform this evening, and we are very, very happy to see you all. As most of you know and have experienced, Right Milners is very focused on education, and we host platforms like these quite frequently. Tonight, our focus will be on the basics of bone grafting, and we are very fortunate to have two of our leading periodontists in the country lecturing and hosting this event. We've got Dr. Bredekamp from Durban. If there isn't anybody that knows him, doesn't know him, I don't know where you've been. Then we have Dr. Toit from Pretoria, and he will be our main lecturer for this evening, with Dr. Bradley just making 100% sure he's saying everything that he should. We are fortunate enough to have our speaker from Khorasan, Dr. Fernando Duarte, here this evening with us. Dr. Duarte is an oral specialist from the Portuguese Dental Association. He has done his post-graduation in oral and maxillofacial surgery, and he is also the CEO and clinical director of the Trofa and Portugal. Thank you guys for spending your evening with us and sharing your knowledge. We really do appreciate it. There is a question, but we'll sort it out for now. So I'm going to hand it over to Dr. Du Toit.
Okay, thank you. Let's see. Just let me know when you can see my presentation and my screen.
Okay.
Yeah. Can you see?
Yes, we can.
Yeah. Yes. No?
Yes. Perfect.
Okay, cool.
Yes.
Thank you. Thank you. Good evening, everyone. Thank you, Right Milners, Khorasan. Thank you, all of you attending. We know your time is precious, so it's pretty cool that you've dialed in to come and have a listen to what we have to say. Myself and Bradley wanted to put together a webinar where it's a little bit less of a lecture and maybe a little bit more like a discussion. Bradley is arguably, he was my examiner, he's my senior, and we still get to debate a lot of things, and that's kind of the angle that we would like to bring to this presentation if we can. So I'm going to go through a couple of slides on the topic of the absolute basic fundamentals of bone grafting, and here and there when I'm saying something that Bradley agrees or disagrees with, or that he can add, it would be nice to see if we can get a dialogue going between us. Well, what we want to cover in this presentation is these 5 questions. Why do we need to add bone? Why do you need to grow bone back after it's been lost, right? How do we manage post-extraction ridge loss, right? How is it done? What are the materials that can be utilized? What are the techniques available? And ultimately, what are the issues with all of these materials and techniques? What are the pros? What are the cons? What are the benefits and limitations? Well, let's start with the first question. Why do we need to graft bone? And the photograph here, this is Christopher. Christopher came to see me, and he was going to lose this tooth. This photograph sums it up as to why we need to graft bone back after it's lost. When you look at this photograph, you're thinking the same things I was thinking when I had to remove his tooth, and you're anticipating some changes following the removal of this right upper central incisor, right? What are the types of changes that you can expect? Something is going to change there. The tooth is lost, there's an extraction socket, and there will be some changes when it heals. And it comes down to the loss of bundle bone. There really shouldn't be anyone watching this webinar, arguably apart from possibly some of the reps who don't know what bundle bone is. Okay, socket changes and ridge resorption after teeth are lost are as a result of the loss of bundle bone. Now, if you have a look at the work by Maritza Arroyo, Jan Linde, there are multitudes of research studies where they looked at extractions in the dog model. they describe two phases. The first change of the socket is because bundle bone is lost, and I'll show you in a moment what it is. And the second phase, with ongoing remodeling and change of the ridge, is basically unknown. We don't know why it changes, and it differs between patients. Bundle bone, let's just address first what that is. Most of you would see it every single day on a radiograph. It is this radio-opaque lining of the tooth socket, right? Some of you who are older in our community would call this the krabbeniform plate, and everyone else would call it the lamina dura. That is bundle bone. On histology, this is some work from our research in 2017. You can clearly see histology, and I'm just going to move my cursor around. Can you guys see my cursor?
Yes.
Anybody? Yeah?
Yeah.
Cool. Okay, so I'm going to point with my cursor. You're looking at some histology of the periodontium over here. You've got this root cementum, you've got the PDL space and the PDL ligaments, and you're looking at just the edge of the socket. And you can see this thin layer is stained like a darker purple is bundle bone. It's that lining of the tooth socket. It is bone that is born to the tooth when the tooth erupts into the mouth and when it comes into function, and when the tooth is lost, bundle bone, she's gone. And if you have a look at a CBCT, this is a CBCT three-dimensional CT scan of a patient's anterior maxilla, ventral incisors, lateral and canine in the horizontal slice. Incisive papilla would be positioned here. Look at the position of the roots typically in the anterior maxilla. How much bone is over the facial of these roots? Arguably almost nothing, right? So that would tell you something. One, that the facial bone in some areas is extremely thin. Our research in the South African population showed that between 80 to 90% of patients at anterior teeth maxilla have 1 millimeter or less. That is super thin. What that also tells you is that facial bony plate comprises almost solely of bundle bone. I said a moment ago, when a tooth is lost, the bone is lost. So it's no surprise that the loss of a tooth in Christopher's case, and regardless of my lab's inadequacy for taking shades properly, but look at the ridge loss. And this is dealing with a horizontal. If you had to mirror the contour with the intact tooth, the sound healthy tooth, onto the opposite side, how much was lost? A fair amount of horizontal loss occurred here. All right. Here's another case. Now we were dealing with the horizontal in that photo. How about vertical loss after tooth extraction? If you look at Burn Working Group in Chapuis and Daniel Boozer, that group, they published from 2013 through to 2015 CBCT studies where they showed CBCTs taken on day of extraction versus 3 months of healing. The average at the mid-facial at central incisors had vertical loss of 7.5 millimeters. The average, 7.5 millimeters. Okay, so how much did this patient lose? This makes a commentary on the type of radiography that you need for diagnostics, and that ties into the overall concept of the fundamental basics of bone grafting. But a lot of practitioners would look at this and go, yeah, right, I've got bone for days here, not a problem. I can place an implant. This doesn't tell you anything. Ultimately, what you need is three-dimensional radiography, right? So here with a virtual implant positioned in position at the missing tooth site, how much bone do you now have? And the question then is also, how much bone do you need? Asking the question, why do we sometimes need to graft bone? Would you agree that trying to park this implant in anterior maxilla with central incisors around 3.5 millimeter diameter to 4 millimeter, park it nicely between incisive canal and within this bony envelope? Do you have enough bone on the facial? Another question is, how much bone is enough? How much do you need? Okay, how about this case? So this is Tony. Tony came to see me. She wanted some replacement of missing posterior teeth. All right. Had she gone to the majority of practitioners, sure, they would note the horizontal loss. I can also confirm she had vertical loss. But what is the issue with placing implants where the bone is, where it has resorbed and healed to, as opposed to where the implants should be planned to a restoration or to what the prosthetic plan is? The issue then is, and all I've done is just outlined these restorations onto the opposite side. The restorability issue. You've got implants placed at incorrect positions to support these restorations at odd angles. And we see this all the time. Wouldn't you agree? Implants placed where the bone is and where it's resorbed to rather than where the restoration should be. And there's a host of complications that comes with this. And I mean, I took this off Google. We see this. There's not a single person watching this webinar that does not see these types of complications weekly in practice. And sure, you can argue and say, oh, but that's a placement issue. It's too far buccal and blah, 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 blah. The issue here is ridge loss, following tooth loss, lack of correct site development, inadequate bone and soft tissue that leads to the recessions, that leads to inflammation, that leads to further bone loss. That's, arguably is a bit of pre-implantitis, but probably started as a site that wasn't developed properly. That answers the question. Why do we need to develop the site first? Why do we need to graft? And I would say that the majority of our implants that we're seeing out there look like this. They don't have any bone over the fascia. I think if you raise flaps over the majority of implants, they would look like this. There's a lot to be said for the longevity. The reason why probably this implant survived are because there are adjacent teeth and they have bony peaks that are supporting this. And this really becomes an issue when you now lose an adjacent tooth. Wouldn't you agree? Because once that tooth is gone or the other incisor is gone, now the collapse happens. Now the recession happens. Okay, so you get the point for why we would need to graft bone back, post-extraction ridge resorption, and the issues surrounding lack of site development. Well, how do we manage ridge resorption? Let's start with preventative measures. The first amongst the preventative measures would be low trauma extraction. Don't call this atraumatic extraction. That's a misnomer. Low trauma extraction. So I'll just go through this as a case of mine. Gert came in. He had failed endo, failed again. The tooth was planned for extraction, replacement with an implant. Here's the crown in position. The crown is basically cut away, so the tooth is decoronated. Okay, and this is a change of mindset for a lot of people, where I think the average dentist feels like when the crown is not there, it's panic mode. Now the extraction forceps don't have anything to grab onto. It's a mind shift. The crown's in the way. For low trauma extraction, the crown is cut away. The tooth is sectioned into portions, firstly through the mesiodistal, keeping the buccal roots joined. And then the palatal root is carefully loosened from within its socket with microperiotomes. I prefer to mallet them so I can control the force. Once the palatal root is out, section the two buccal roots and then carefully deliver them one by one. And this is not a race. This is not who can extract it the fastest. I'll never forget a story. One of my good colleagues and friends down in Cape St. Francis, Dr. Michael Jones, was telling me about a colleague of his extracting a tooth, upper molar, struggling for ages, sweating, and eventually when it came out, showed everyone, yeah, that was what was holding it in place. And he had the entire buccal plate stuck onto this molar tooth that he just fractured off. Now, the buccal facial plate in implant dentistry, regenerative dentistry, is absolutely golden. So this technique, which is to take a molar tooth planned for extraction and to section it into its individual roots and take it out piecemeal, and then probably the most important step, to clear out any apical pathology and have a preserved extraction socket with the least amount of trauma, is absolutely important, absolutely key. Right, and it is crazy that still at universities around this country, this is still being taught. I mean, I was taught this. I can tell you that undergrads are still being taught this today, and that is extraction forceps over a ferrulous root or root without a crown to basically crush the alveolus and remove this root. And that's not an old textbook. That textbook was published, 2016, 2017. This photograph, I had to show you this because this was a post-extraction healing in a patient by two of my students at the university. They had removed a canine and a premolar in this patient and had surgically, right, so they've been told to drill away the entire facial plate so that they can get to the roots and deliver them through that window. The amount of destruction that has occurred here is painful. It is just unbelievable. This is not the way. Low trauma extractions don't look like this, and this should not be done for training dentists. Arguably, what they should be learning is how to do low trauma extractions.
So, Jonathan, can I add something there?
Yeah.
Can you, I would also just add that you'll see we use it a lot here, and many of you know you have to use CBCTs for all these things, not not a pan, not periapicals, because with your low trauma extraction, like the case he just showed there, remember you're trying to preserve bone. So you need to measure on your CBCT what is the length to the furcation area, because you're not going to go take a burr now and drill through those roots and go and destroy the bone mesially, distally, interproximally as well, because you need that bone. So you need to plan before you do extraction on your CBCT, how deep you're going to go, where you're going to access it, and so forth. Sorry.
Well, here's a comment, and I think what Brad just said, he's starting to speak to the steps and the teaching and how to do this, and obviously my step-by-step photos will do that as well. My argument would be, why is this not being taught at a university level to training dentists? Every single graduating dentist in this country should have a quota in the training that shows them how to take teeth out low traumatically. I mean, it's an absolute must, and it's crazy that in 2021 this is still not being taught. Anyhow, okay, moving on. So we're talking about preventative management. Here's a different type of scenario. This is arguably one of my best GTR cases. Sadly, ended up in the bin. He had regenerated all the way from molar root apex right up to here. Bone, well, it's arguable. Anyway, hard tissue. These are the tacks that are left over from the membrane that was draped in this area, but this patient had developed root caries and the tooth had to be extracted. So Rachel was going to lose her lower right first molar. This is the pre-op photo. Note the buccal contour. Again, low trauma extraction, tooth is decoronated, roots are split, periotomes to deliver mesial distal root, and then the socket was grafted. So now we're talking about the second preventative management, which is ridge preservation. Don't call it socket preservation because we don't preserve sockets. We preserve the alveolar ridge. We are placing a material within the extraction socket with the purpose of trying to prevent its volume loss. That's arguably the definition of socket grafting. And there have been hundreds of different variations and recipes of different bones and techniques and flaps and grafts and membranes and things to use. In this case, I think we used this was a sintered xenograft, and we're going to get to the types of materials in a moment, combined with the plasma portion of PRF. There can be some questions maybe in the chat if anyone wants us to describe what PRF is. So there's the material, sticky bone, packed within the extraction socket. This is the PRF clot that's been squashed out flat into a membrane, draped over the socket and sutured in position, right, to contain blood clot, contain the material, prevent contamination, etc., etc. So the socket has been grafted as an experiment. This is one of my few socket grafts. Okay, now let's have a look at the after versus the before. So this is a 3 months healing on the left, the after. There's a line I've drawn of the buccal contour, and you can argue, okay, maybe the inclination of my photographs are a little bit different. Let me ask you as a viewer, if I show you this case, how much horizontal collapse? Get the vertical. Let's just do it horizontal. How much collapse occurred here? 1 millimeter, 2, 2.5, 3. All right. Weigh up the cost to the benefit. In everything we do, there really should be a cost to benefit ratio. So if the benefit is that you're going to prevent some collapse, what is the cost to the patient? Your time, the cost of the materials. These biomaterials are not free. There's an argument for and against here. Okay, let's have a look at the literature. Let's explore that argument for and against. So this is some very new literature published by a team, 2 of them I'm friends with, Gustavo and Leandro. This is a meta-analysis. Let's just talk quickly about what a meta-analysis is for those of you who do or don't know. A meta-analysis is basically a statistical analysis, right, using math, research math, to take randomized controlled trials, which are when you test doing something versus not doing something, and you randomize it. So that's supposed to be the highest level of research and evidence. You take all of those on a topic, combine them, and then you add some math to it, take the data. And then that is supposed to be the very, very highest order of evidence in medicine or in science. Okay, so this is a meta-analysis about alveolar ridge preservation following socket grafting, basically. Okay, so this is the results from the article. And I've studied these. I studied Fabio Vignelletti's 2014 version backwards. I've debated it with him. They debated this version with Gustavo and Leandro backwards. It reads so difficult. The wording and the interpretation and the way that researchers present their data is overwhelming. I feel overwhelmed. Maybe you all don't, but let me read this to you. The results of a pooled quantitative analysis revealed that alveolar ridge preservation via socket grafting, as compared to tooth extraction on its own, prevents horizontal, vertical mid-buccal, and vertical mid-lingual bone resorption. And then they give you figures of how much, right? So I've circled just this one here. Let's just deal with horizontal to keep this bite-sized for us. So they're saying by socket grafting, you can prevent is that what they're saying? 1.99 millimeters? Let's put 2. Is that really what they're saying? It's a bit confusing. Are they saying that extractions alone prevent that? That socket grafting prevents that? Well, how much happens, or how much horizontal loss occurs just when you do nothing? What you're actually looking at here is something called a weighted mean difference. That means the difference on average through all their statistical analyses between the two techniques. So if you extract a tooth and do nothing and you lose 5 millimeters horizontal, by grafting the socket, you are going to lose 2 millimeters less. You get that, but you're still going to lose something. So how do you clinically apply that to make it relevant? So part of our PhD, just one of the small studies we did was to look at the faciopalatal dimensions of anterior central incisors to apply this knowledge of post-extraction ridge changes by Gustavo Villa-Ortiz and his team. And I measured out, on average, I can tell you, in the South African population, between about 7 to 8 millimeters. From buccal plate, central incisor, to palatal plate is about 7 to 8 millimeters. Let's be generous and say most of our patients have got a width in total before extractions of 8 millimeters. If the meta-analysis, let's do some math. If the meta-analysis says that even after you graft a socket, you're going to lose about 2 millimeters, how much horizontal width do you have? It's easy math, right? Well, for a central incisor, what size or what diameter implant is typically placed at a central incisor in the maxilla? Around 3.5 to 4 millimeters. Would you all agree? So how much bone do you have either side of your implant? Revert back in your mind, your memory to the slide I showed you 10 slides ago with all the complications. Sites that have resorbed, that weren't properly developed, that didn't really have enough bone, that didn't have enough soft tissue. If you take an implant that is 4 millimeters in diameter and place it in the central incisor, on average, even if you socket graft the socket, you're going to have 1 millimeter on the facial and 1 millimeter on the palatal, if you're lucky. So what are you probably going to need to do in every single case? You're going to have to graft again. So this is about where I was supposed to put Dr. Bredekamp's slides in, but they come in later, so I'm going to skip this. Let's continue on to preventative management type 3, partial extraction therapy. This is nothing new. This is, some of the techniques have been around since the 60s and 70s. That is root submergence. The socket shield technique has been around now for 10, 11 years. I mean, these are not new techniques. This is part and parcel of everyday implant dentistry nowadays. So preventative management is to use also part of the patient's tooth roots and partially extract. Don't fully extract. Okay, so this is a patient who was going to lose all 4 anterior teeth. And my prof told me, and told the patient, this is absolutely untreatable by dental implants or challenge accepted, prof. Have a look at this case. All right. Well, presenters only show their best cases. It's fine. I'll show you a few more. This patient only ever had 1 surgery, 1 procedure. It's a gamble. If I'm lucky, she'll never. Can you imagine the amount of reconstruction that would have to have happened here from canine to canine in that portion of the arch? Removing all 4 incisors for that to collapse, come back, augment the bone, vertical and horizontal, augment the attached keratinized tissue, develop, then place implants. Preventative management, partial extraction therapy, super valid. Let's move on. We talked a little bit about preventative. Let's talk about corrective. And that is doing treatments after the loss has occurred. So this is the case I showed you earlier. okay? And this is the defect once the implant is placed. So my question to you all as viewers is, how do we manage this? What can be done here? I'm going to show you a classification by Christoph Hamel and Benich, and I'd like you to try and remember this photo in your mind, and by the end of it, tell me what type of classification of defect this is. And at the end of the lecture, be able to identify what features of this site make it amenable or make the prognosis positive or good in terms of grafting, and what features of these sites are in its disfavor, that are not in favor of grafting bone here. Okay, well, let's have a look at that classification published in Periodontology 2000. For those of you who read this literature, this is the Bible of perio literature by Benich Hamel. It's one of the few classifications on ridge defects that is really quite good. And sure, I can critique it, and I'm going to in a moment. And there's a lot of things that didn't take into consideration, but it's one of the few classifications that really started to look at these features. Think of the phrases I'm going to mention now: graft stability, space maintenance, and osteogenic potential, and where those come from, and what type of bony defect has those different features, how they differ. So this is a classification, but given this is kind of my spin on it. On the right here, you can see my notes, and over here is just I've reworded their classification. Let's go through it didactically, step by step. Okay, this is a class 1 defect cross section, and they call a class 1 defect basically just a contour defect. It is a minor horizontal defect. The implant is mostly contained within the bony envelope. You can see it there in the diagram, but there's just sort of a dip on the facial. The treatment they would recommend for a class 0 defect would be guided bone regeneration, purely just to correct the aesthetics, right? So the augmentation, in their opinion, for a class 0 defect is not critical to the implant's longevity. I would argue against that and say that this is the most critical area. Peri-implantitis doesn't happen at the apex, it happens here, the bone crest. And having the minimum bone on the facial or circumferential to the implant of 2 to 4 millimeters is absolutely essential. So it's more than just aesthetics. My critique is a massive variation in types of contour defects. Not all of them need GBR. In some sites, and we're not talking just anterior sites, think of possibly a premolar site, a soft tissue graft could do if we think in just about aesthetics. Okay, next type of defect. In the classification, a class 1 defect is an intraalveolar. This is simply an immediate implant. So it's an implant that's been placed within an extraction socket, and there is a buccal gap, or some people call it a jump gap. And that can be grafted if larger than 2 millimeters, and I would argue that I would graft the gap every time. Okay. They also mentioned something in the classification about raising a flap at immediate implant placement to view the buccal bone and decide if GBR is needed. I disagree with that. Raising a flap is going to cause more trauma, is going to cause more resorption, and your planning whether you need to do a GBR is going to come from what? Your CBCT view. Professor Bradley, feel free to chip in at any time. Okay, next defect, a class 2 defect. So this is termed dehiscence. So they describe it as the volume stability of the augmentation is provided by the adjacent bone walls. And this, for those of you who want to attend this to learn some fundamentals of bone grafting, is such a fundamental concept. If you're going to graft bone, where does your graft stability come from? Right, this isn't just polyfiller plaster onto a flat wall. Where is your osteogenic potential coming from? Where is your graft stability coming from? Where is your space maintenance coming from? What type of defect offers you those 3 features? So for this type of defect, a class 2, they're saying that it's coming from the adjacent walls. Think of a missing tooth in the anterior where the bony peaks or the eminences of the adjacent teeth can somewhat maintain that. The treatment recommended would be guided bone regeneration with a resorbable membrane. And I would agree, that's probably ideal. The majority of the primary stability and the osteogenic potential of implant placement is coming from the residual bone. Okay, this is probably where I again disagree with this classification. From here on, the line here where they were separating the first 0, 1, 2, 3 classes from class 4 and 5, where they would say one should first wait and augment, I would say probably these last three. You should wait and augment later. Augment and then wait for implant placement later. Anyway, a class 3 defect is termed a dehiscence. Volume stability of the augmentation is not provided by the adjacent bony walls. We'll show you some clinical cases in a moment. And they recommend the use of a PTFE non-resorbable reinforced. This has got titanium in it, so it's a rigid. The membrane is there to provide the space maintenance, the graft stability. And I would say, yeah, you don't have to. You just use a PTFE membrane. There are other titanium membranes. One could use certainly an autogenous bone block. Those rigid augmentation approaches could provide the space maintenance and the graft stability. Okay, 2 more to go, and then we'll show you some cases. The class 4 defect, which is a severe horizontal defect. And it says here that it precludes adequate primary stability of your implants, and therefore you must first augment. And they recommend the use of autogenous bone blocks. I disagree. Possibly you could place an implant at the same time and augment over. If you see a lot of the bone block cases on social media, and the graft is done first, then the site is exposed, and then the implants are placed, it's mainly if you ask those practitioners so that they can get a really good photo opportunity of how much augmentation they got and how good the augmentation looks. You could do the two together, but yeah, disagree, agree. Brad, anything you want to add?
I don't disagree. I think it depends on the volume you've got, because the essence here is that you don't have enough bone around the implant, and now you're filling it with titanium and you want blood supply. So it depends how big the area is, like you said, where you're going to get your blood supply from, the adjacent areas, the span that it's got to cover. So it's not hard and fast, but there can be cases where you have to do it in a 2-stage.
Yeah,
but I agree
100%.
with you, not always you must do a 2-stage.
Yeah, so it's just, I have a tendency to be a bit of a devil's advocate here. So if they say that you must wait, the previous one, they said you don't have to wait. I said, yeah, you must wait. I'm just debating it a little bit here. And then the last type of defect is both a horizontal and a vertical loss, right? So a massive defect that needs to be reconstructed 3-dimensionally. And arguably, there are some techniques that have been purported to do this effectively. I don't know if any of you have heard Istvan Urban's sausage technique, which is basically a GBR, but to make a sausage, if you will, in the name, right? And grow bone vertically as well as horizontally. Just go and type in sausage technique somewhere on PubMed and see how many research articles you don't find. Yeah, there's almost none. And I would say that the mainstay of treatment for this would be 3-dimensional Curie bone blocks. Okay, right. Let's move on to the types of materials. So some of this is dental school training for yourselves. You would know some of these terms. And this is where myself and Bradley will start to share information. He'll chip in and say some things. We really couldn't, within this lecture time, tell you and argue and debate on all of the features of these materials and go through all the different variations. Because let's just, for example, when we get to xenograft, we'll probably pause and say a hell of a lot, and synthetic, because there are so many different types underneath a xenograft and a synthetic, for example. No two are alike, really. There's massive variation. But the 4 main classes are autogenous bone, autograft, allograft, xeno, and synthetic. Autograft means it's bone that comes from the patient itself, right? This photo depicts going to the buccal ramus in a patient to harvest the block, and this will be split. So this is the Curie bone block technique, right? There are other ways to harvest autogenous bone from a patient. This is called a safe scraper. It has a little blade in the front, and it has this sort of plastic see-through compartment where the bone shavings collect. There are drills that you can drill into areas of the jaw, automax drills, etc., that can harvest bone quite quickly and rapidly. Bone chips, auto chip makers, all those types of things. So there's a few ways to harvest autogenous bone. Oral surgeons would go to the hip, right? There's that. Allograft, as we move down, this is further away from the human, right? Allograft is from a dead person, cadaver bone, donated bone. There's a company in South Africa that offers this. There are some commercial companies that include this in their product range. So it's bone from another person. Brad, you want to just add something? Do you use allograft much?
No, I don't really, because I don't get great acceptance from patients to have somebody else's bone in them. They'd rather put an animal in them than another bone. It's been my experience in practice.
Right.
I think most people go for this because it's of the price. It's the cheapest. Besides autogenous, it's the cheapest option.
Look, autogenous is basically free unless you're using a disposable harvesting tool or instrument, for example, a safe scraper, right? That's arguably a tool that you've got to buy, but the bone material itself is free. Allograft, there's a company in South Africa that makes it. It is quite cheap. It is widely used. There is also massive variation in the product range. That's got varying amounts of cortical component, cancellous component, collagen component. Allografts from companies in Europe that are commercial even come, they make these cortical plates. So you can get a ready-made little cortical plate. That's an allograft material. What can we say about the differing properties between these two, Brad? Autogenous bone has got your own living cells in it. It's the only material that you can say is osteogenic. It makes bone directly. It has bone-containing cells. Okay? None of these materials you can say are osteogenic. All the commercial products that we know are purely osteoconductive. They provide a scaffold. It's arguable whether they are going to inspire bone. And I don't know, Brad, you can debate this with me. To my knowledge, the FDA definition of whether a bone is osteoinductive, whether it induces bone formation, means that it must have been tested in a different tissue other than a bone site, and histologically must have been proved. For example, they would take, I'm just being hypothetical here, let's say an allograft material, and they went and put into rabbit muscle, like in a leg, in a research study, and it was proven to have formed bone in that site, you can say is osteoinductive. Okay. Brad, any other properties you want to add about these two?
Nope. Well, yeah, kind of. It's fine. You're doing well.
Okay. As I keep going, when I get
Sorry,
to the
Dr.
last...
Toit.
Yeah.
I don't know if this is considered a silly question. I just wanted to find out, obviously on the allografts, you also get different types. You get bone that get harvested from cadavers, but you also get bone that's harvested from live patients. Is there a major difference? Is there concerns between the two? Would you prefer the one over the other?
Yeah. Bradley?
As far as I know, you wouldn't harvest bone from a live patient to use that bone as is into another patient, not in our field,
No.
at least. We
Okay,
don't do
so
that.
there is companies that say that they have a bone that they sell as an allograft that is harvested from live patients. Does that not then fall under this?
But the bone has to be processed if it's...
Yes, obviously processed, yeah.
Well, let's rein it into what are the messages that we're really trying to share with an audience here, and that is the fundamentals of bone grafting. Really what the slide and the next one are trying to share are what are the main features and properties. I mean, if you've long forgotten what are the types of bone available and a product representative comes to visit you and says, hey, here's my product, you can use this in all scenarios. Arguably live patient transplant allograft, I'm not familiar with it, and I'm 100% sure it's not available in South Africa. So if we rein the topic in and just scrap that for a second,
the question
let's focus on.
Sorry, just to answer that. The question I would ask is, what's the benefit of harvesting the bone from a live patient? Because you can't take that bone and immediately put it in somebody else. It has to be processed, and if you're processing the bone, you're losing the little benefit potential from having taken it from a live person that you may get. So to me, that doesn't make any sense.
Yeah, it's a cool topic and it's a cool question, Celeste. You stumped me a little bit there, but I'm just gonna scrap it in terms of relevance.
One of your colleagues actually mentioned that the reason he would prefer the bone being a donor bone from a live patient over a cadaver bone, obviously being processed and going through the whole process like Bradley says, is he says there's certain diseases that can't be tested on a cadaver. But as Bradley said, it won't be relevant because it has to go through that whole process of, then it won't matter what the disease is. That's kind of what I'm trying to get at. Is that correct?
Yeah, but let's not focus on that, because what we're going to do is we're going to draw attention away from what is actually available to, debating something that is cool and, that's actually not really relevant. So I'm going to move on, shut that down. Xenograft material. Xenograft means it comes from animals from a different species, and typically the types of bone materials that is depicted in this column would be from pigs, cows, horses. It doesn't sound cool to say that, so we tell patients and other doctors that it's equine and porcine, but it comes from animals. There's an ethical component to it. Obviously, we're a multiracial, multi-religious country. You've got to disclose that to your patients where it comes from. Let's talk a little bit about the properties, where only autogenous bone is osteogenic and the rest are mainly scaffolds. What type of scaffolds are these materials? And under xenografts, and this is great where I've got Bradley to kind of debate with me and chip in, there's massive variation. What's depicted in this photo is a sintered xenograft. It comes from cows. When I say sintered, it's been prepared and put into a furnace and cooked at 1,000+ degrees Celsius, right? So when it comes out, it basically looks like a crushed porcelain plate. It's pure hydroxyapatite on bone, right? In terms of handling properties, it's very difficult to handle this material versus handling autogenous bone scrapings. We typically add biomodifiers to it. This is where sticky bone, PRF, the plasma comes into play. Versus on the other end of the spectrum, xenograft materials that have been collagenated and have like glycerin in a putty. So this is a syringe with a product that's widely available in South Africa. It's also an animal bone, but it comes in like an injectable putty form. And they behave very differently. This material, and I've got a photo, as I thought of this, I forgot to put it into the slide, but I've got a photo of a skull, basically with a xenograft. It's probably what the sintered material was. This patient had an augmentation, and even years and years later, after passing away, that material is still there. It does not resorb. Some people want to be kind and call it slow resorbing or slowly replacing. The collagenated materials, Brad, again, correct me if I'm wrong, they do and can resorb greatly, if not completely or rapidly.
I think the other problem is that, you see, with the first two categories, it's very specific what they are. With the two latter ones, there's a broad degree of variation that falls under the same heading. So, for example, with xenograft, like Jonathan said now, it ranges, and when I started out in practice, BioOS was the main one used globally. In fact, I remember once reading an article that said at that time that every 30 seconds somebody in the world was putting BioOS into somebody else. That's how often it was used at that stage.
The most widely researched bone material in the world is that material.
Exactly. And the problem is when they research BioOS, and it's a sintered, so it's basically glass, and it's not got a lot of biological properties. But the problem is it's widely researched, and when research is negative towards that material, it categorizes all xenografts as negative. And that's not always a fair thing, because you're not comparing apples to apples. And when you're dealing with the collagenated types, then they have different biological properties to these, and we need to be wary of that in our system.
So the key is, if I add to this and try and tie it together for you all, is that you're going to be overwhelmed with choice. You're going to be overwhelmed with an asymmetry of knowledge. That means you might not know all the materials, all their properties, whether it's handling, whether it's resorbability, whether it's whatever it may be. You probably focus on cost, right? In the climate that we work in, the first question is, how much does it cost, right? Not does it work, and how does it work, and can it work, and can I use it in all circumstances? The answer to that last question is categorically no. There is no material that you can use in absolutely all scenarios, or should. Anyway, xenograft, those are the properties. There probably is a lot more that we can add to it, but we'd be here for hours. Let's move on to synthetic, okay? Synthetic, I heard someone once use this term incorrectly as a misnomer to say synthetic means all of these materials because they're commercial. No, the heading probably would be here, commercial biomaterials. Synthetic means it was made in a lab and it had nothing to do with anything organic. It didn't come from an animal or a human. Okay, so the synthetics would include the variations of calcium, sulfate, silicate, etc. And again, there's massive variation between the few types that are available. This is, you can read it on the bottle, so it's a pure phase beta tricalcium phosphate. This is a tricalcium phosphosilicate, if I'm right, and it comes in an injectable putty. You get, on the other end of the spectrum, hydroxyapatites, synthetic hydroxyapatites that are, if we talk in properties, much slower resorbing. On the other end of the scale, this material is supposed to resorb rapidly, and the benefit is proposed that if it resorbs rapidly, that it forms bone rapidly as well, right? We can debate that. Then there's some companies who try to mix the two. So if you wanted to have a material that can not resorb very quickly, mix them with material that resorbs quite quickly and forms bone, start to ask yourself questions like, why do we need these different materials? What's the difference between this material that resorbs rapidly, right, or autogenous bone scrapings that form bone rapidly, versus, say, this material, which is a sintered, I told you, it's a sintered xenograft that's basically cooked, sintered, pure hydroxyapatite that almost never resorbs. And the argument would probably be that this material would stay there. So in what scenarios would you want a material to stay there, basically maintain that space and that augmentation indefinitely? Okay, let's move on to some of the adjunct materials, because bone grafts, up until maybe one of the most recent materials that's hit the market and also seems to have biblical results. We'll talk about that just now. Most of these commercial materials need adjunct materials, that is, barrier membranes and fixation materials. Barrier membranes are divided into resorbable, that get resorbed and disappear over time, versus unresorbable and require a second surgery to go and remove them. Some of them can be reinforced with titanium. We referred to this earlier in the classification. Can you see this sort of shape of titanium within this PTFE, or dense polytetrafluoroethylene membrane? And this one doesn't have it, right? So this is from a different company, but the same material, it's just blue. This will maintain its shape and provide space maintenance and graft stability. Okay, and this would fix it in place. These are pins that you'd knock into the corners to hold the position. There are other ways to also hold a membrane in place, and I've just sort of put this photo of mine underneath resorbable membranes, because here resorbable sutures were used to hold this membrane in place, versus pins that would be hammered or tacked in the corners. And in this type of, this is, if you can call this a membrane, a titanium membrane. It's rigid, non-resorbing, and it uses the healing abutment or a screw to basically fix it in position. So this just gives you a quick, rough overview of the materials that can be used. Let's go back to this photograph at the beginning of the classification. What type of defect is this? I don't know if the moderators can have a look at the chat. Is there anyone who was paying attention and would get this classification right? Is it a class 0, a 1, a 2, a 3, a 4, and a 5? Is it a defect that precludes implant primary stability and placement at first? Is it one that must be grafted with a rigid membrane? What are the recommendations here? Right, where's the graft stability coming from? Is it from the adjacent bone peaks or not? Right, this is how this case was managed. I'm not going to answer those questions. I want you as the viewers to be able to answer them. This is how it was managed. It was managed with a resorbable collagen membrane. This is a template of what would fit at the site and what I wanted, sterilized and then cut out in the procedure. This is a sintered xenograft. Squirted over it is the plasma from PRF that forms this sort of malleable patty. We call it sticky bone. And the beauty of this biomodifier, if that's what you want to call it, is that it makes this material, it drastically changes its handling properties. And we can have a whole lecture just on PRF in itself, and whether some people debate that it has growth factors and healing and this and that. So that's, if we're talking about handling properties that revolutionized how we use, can you see how this material that would have just schmutzed all over the place here, right? And forgive the bloodbath, those of you who do surgical photos would know that to take these type of photos is tough, but what you can appreciate here is this is a guided bone regeneration procedure. This is a sintered xenograft, particulate commercial bone that was packed over the minor dehiscence over the implant that had most, if not all of its osteogenic potential from its implant osteotomy. And the adjacent bony peaks are providing minor stability to this graft. Would you agree? Where's the graft stability and the space maintenance coming from? The graft stability is coming from this collagen membrane. And what's stabilizing the collagen membrane? Pins at its apex and a sort of a sling suture and a typical tension relieving suture, right? What's providing the space maintenance of a graft? What's rigid? It's this actual concrete material itself that is arguably never going to resorb. That's providing the space maintenance for blood to flow in between the particles, get remodeled into granulation, osteoid, and then eventually into bone. Okay, so that's how the case was managed. She also had a crown lengthening in the procedure, later a veneer and a crown and blah, blah, blah. Okay, corrective management continued. Let's have a look at the case from Dr. Bredekamp.
So this is a case that I had, I think it's about 2 or 3 years old, and you can see there's a big defect on the mesial wall of that forceps. So I decided to extract the tooth, and I did a ridge preservation. And yeah, I actually used a xenograft, but I used a collagen-nated xenograft with a sticky bone. Placed it in, just packed it in. And I know Jonathan's not a big fan of these ridge preservation techniques. I use them, and I think they are a useful tool for general practitioners, because let's be honest, most of the reason why dentists are using these synthetics or the xenografts is because most are too scared to go harvest bone to do a curry plate and do the have the technical skills to go and augment like that. It's not because of cost, I think. Firstly, I think it's just because they think it's too difficult and daunting a task to do that. So you're going to try and go for the simplest thing, and the simplest thing is to clean it out and just shove something in there to pack it in, because that's what we do with fillings and everything. So I did the xenograft. We waited about 6 months, and 6 months later, the patient came back, took another CBCT to see. And Jonathan, can you show the next slide? And this was the result after 6 months.
Yeah,
now, that's
okay,
not
so
yeah.
I'm going to interrupt Bradley here. There's 2 things that he can do. He can grow a buccal plate from socket grafting, and he can also part the Red Sea. 2 things that I can't do. But there's a reason why I invited him to do this this webinar with me, so that because we have these debates, for and against, and I think it's really fair that you guys get both sides or multiple sides. Carry on, Brad.
So if you look at the CBCT, because you'll say, yeah, that would have filled in any case to that level. Can we look at the CBCT? Next one. So if we look at the sagittal, here you can see there's the molar tooth. No, go back. You can see absolutely no buccal plate there. So if I just took that tooth out and left, that bone would most probably, and if you can move it, go at a diagonal line across to the lingual plate, right? It wouldn't say that. Yeah, thank you, Jonathan. But if you look at the CBCT after the augmentation, look at that volume there that we've gained, that width, that's there. Okay, there's actually a buccal plate that's formed from xenograft, and I think we've got clinical photos. I opened it up because sometimes it's all mush and soft inside, and you think, yeah, it looks good on the CBCT. And that was with the healing abutment. Sorry, I think there was another picture. I don't know if it is. But anyway, there's the healing abutment. Look at the tissue volume we've gained. The only thing I would do different now is I would must probably use the cervical abutment, although you can see there wasn't that much space. But that's just graft packed in there with it at the time of extraction and weighted. And from a cost point of view, I don't think it's that expensive. Even with the second surgical procedure to the patient, you're going to take the tooth out. Patient comes back, and all of a sudden your implant placement now becomes a straightforward implant placement we teach somebody at a basic academy course, because you've got enough volume of bone there and you just have to place it in.
So let me ask you this question, Brad. In your experience and opinion, would you say that it is predictable to get a regenerated buccal plate when it is gone like this from a socket graft?
I can tell you that I've been doing this for over 10 years, and I don't have a handful of cases with this. I've got loads of cases with these results.
Okay.
How
Cool.
that's
I mean,
why I said,
I'm happy to debate it, and that's why I wanted you here for this. It's fine.
because that's what I'm saying. There's a theoretical knowledge, and again, you've got to look at the context of which things are put in, and you can't just go literature based, because it can be very much skewed. And then I use it in my hands and see, do I get the same results? And I'm a skeptic. So
Okay, Brad.
I'm the biggest skeptic. But if I see something work time and time again in my hands, then yes, I think it's worth looking at as an
Quickly,
option. I'm not saying
let-
every
let-
case is going to do this.
let's talk about material here. I'm not talking brand, but what class of material did you use?
I said this was a xenograph, the collagenated xenograph material that I used as a
Collagenated
screw bar.
xenograft. Okay.
Yeah, because at that stage, this is what I was using predominantly. I've moved on to the synthetics now to see. So here's another
Okay.
interesting case. Okay, so this is one of my worst cases and one of my best cases. If I didn't get the outcomes that I got, I would have been embarrassed to show you this. But I'll explain to you my thinking process. So this young lady, she's 28, comes to me. She needs to replace this tooth. As you can see from this picture, that space is virtually the size of a single incisor, slightly more than a single lower incisor, but she's missing 2 teeth there. So I decided, well, what do I do now? Because I don't know if I can fit an implant in there. Now, you would think you're going to put an implant in the center would be the right thing, but I'm against it. We were taught, don't put an implant in the middle of 2 teeth. You put implant on one of the teeth and cantilever. So this is the CBCT we took before, and I wanted to show you, look at the width of the ridge she's got buccolingually. That's a 4 millimeter. So I thought to myself, well, the narrowest implant I would put in there is about a 3.3, and Jonathan nicely explained to you the amount of bone you need on either side. So I said with her in appearance, I said, look, even if I wanted to put in the narrowest implant that would work there for a cantilever, I'd have to do a Curie augmentation now, because I wouldn't just put particulate on there. If I can squeeze 2 narrow implants in there and it doesn't work, then I'm going to have to do a Curie implant. So what do you think we try? So me thinking I'm the big shot, I take 2 Straumann 2.9s and I squeeze them into that area to fit 2 teeth in. Okay, and I think I'm going to show this as one. Look what I achieved. And this is a recent case. I did this end of 2019, beginning of 2020. And what happens? Surprise, surprise, it bombs out. Both implants fail. You can see the bone loss on either side and interproximally. What was I thinking? In hindsight, that's going to happen. So I get the young lady in. I open it up. You can go on to the next one.
Mm-hmm.
And that's what she looks like. I open it up. There was no infection, though, pus draining from there. But huge defect there. Okay, next one. Just one more picture, just to be a bit close up. So look at that size of that defect. What's my saving grace here, though, is I do have bone on 3 sides, like Hammerly-Them's class 2 classification. So I've got bone coming from the side, because remember, it's not a wide area. So I'm thinking to myself, okay, this is a bit of a problem. But I said to the young lady, look, at this stage, we got one of these synthetic materials, beta-calcium phosphate and a calcium sulfate material that came into the country. And I thought, let me try it out just to see what it does. And if it gives me a little bit more bone, then I've got a bit more of a base on which to place my Curie plates onto. So I took this material, and
So
the nice thing
Brad,
is they claim this. Sorry?
Brad, this is a synthetic material, right?
This is synthetic material.
Did you use membrane?
No, because this material, they say you don't have to use a membrane, and I didn't want to add now cost to it. So I thought, and I got nothing to lose, because I'm going to have to augment this case in any case with a Curie, my thinking now, at my cost, because I wanted to take the chance. And so I put this material in, and I suture it closed, like that. Passive closure, and that's what we started before. And I waited about 5 months, and I thought, let's take a CBCT to see how much, and that's what I get after 5 months. So
this was your defect, right?
Sorry,
that was your original defect, and I'm circling out here. This is the material, right?
The one on the left was the original. The one on the right, not the defect. That was when we started.
Yeah.
The right was after we put in the synthetic and we'd waited, and you can see the material over there. So yeah, remember, I'm going back to the first one. That was the 4 millimeter put in in the original bone, look at the 4 millimeter and the volume of bone around it. As you can see on the measurement, it's the same. The length is different, but it's both a 4 millimeter diameter. And suddenly look at the volume of bone we've got there. So I'm thinking, whoa, this is amazing. So I'm saying to this patient, look, wow, I'm not sure if I need to do a curry plate now, but let's go in and see, because I'm expecting to drill in there and it's absolute mush. And open up, I can spread the layers away. So we raised the flap. That was what she came like the day we were going to open up. And this is quite recent, about a month. And there's the bone, and there's my implant. And it's solid. In fact, I managed to get ISQs of 76 all around it. It was quite hard, the bone that I got in there. And it's bleeding. And that's pathetic. You can look at the CBCT. Again, there's one with the implant in it.
That one. Wait.
No, there should be another one. No, there's one afterwards with the implant in the CBCT. No, there's one with the implant.
That's your last slide. This is your last slide. Sorry.
CBCT. Sorry, there's one with this implant in, but I've actually got I've got more than 2 millimeters of bone buckled to that implant in a situation where I didn't even have enough bone to start with in this patient to put a implant in there. And it's all synthetic bone material.
So to be a devil's advocate here, in your experience, in your knowledge, do most, if not all, synthetic materials behave like that?
Well, I don't know, but you see, I'm a bigger skeptic for this material, and I can tell you now, I've got about 5 ongoing cases that make this one look like child's play, where bombed out bone loss around implants of note by others that I've augmented. They're coming in to be, because this material's only been available since the latter part.
I'm saying, do you get this, in your knowledge and experience, do you get the same results with other synthetic materials? Growing vertical, horizontal, and everything turning into bone. Boom. With no membrane, just throwing the...
Not with no membrane,
no.
Not with no membrane. So the difference here is, this is the first one I've used like this with no membrane, because all the others I've done like the space maintenance, the tacking, the stability. This one I just slept it in and closed it up and was expecting to be an epic failure. And I'm surprised, but one swallow doesn't a summer make, like they say. So I'm not advocating for this. I'm just saying is I saw guys showing these kind of results and I thought, nah, too good to be true. I've had this and I'm like, okay, well, wait a minute. Now I've got a couple of cases ongoing where I want to see what happens, and maybe we'll follow up and we'll show you those cases if they work. If they don't work, maybe we'll be quiet.
Well, we're gonna wrap up the webinar, the discussion, if you will.
Okay. One more slide in there? No. Okay.
No, that was it. We're gonna tap the webinar, the discussion now with 5, 6, 7 different scenarios, and discuss, between myself and Bradley. I'll pose questions to Bradley, what to do in these scenarios, and what are the issues, what are the pros, cons, benefits and limitations of the different materials and techniques. So here we have Christopher again, his center incisor that was extracted. Brad, what to do here? How do we graft this? Socket graft, yes or no?
You see, well, here's the thing, Jonathan, to answer the question. The problem is you cannot have one rule that goes across every case. So you've got to know what are your options available, and then you've got to do it on a case-by-case basis. You need to see what is the periodontal phenotype of the patient, what is the nature of the defect, how many teeth are their teeth adjacent, how big is the span.
Well, so let's deal, Brad, let's deal with this case then, because they have given you a specific case. You're looking at it. Socket graft this guy, yes or no?
But is there buccal wall? How thick is the buccal wall?
He had an intact facial bony plate.
Okay. So in this case, I would put the implant in immediately and graft the jumping gap. If I can't do a socket, if I couldn't keep the tooth and do a socket shield.
You're the average dentist who does this extraction and are not going to do an immediate implant because of the technical difficulty. You don't do surgery yourself, etc., etc. Grafted, yes or no?
The average dentist should refer to somebody who's going to do that, because you shouldn't take a tooth out and then send it to somebody else if the tooth is not absolutely terminal and has to come out.
So that's a really good point.
The point we've got trying to make it, guys, is there are different kinds of grafts that you can do. There are different kinds of materials that you can use. But you need to understand what the limitations are and what the indications are for whatever you do. You've got to make the right decision. And sometimes the right decision may be more than one decision. I may do it one way, Jonathan will do another way. We may both get a good result at the end. So that's why I say we're not trying to tell you, you must do it this way and this is what you're going to get. We're trying to get you to think, because I see dentists and specialists even just slap up any particulate bone material onto the buckle of something and think that that's going to make bone happen. And then when it doesn't happen, and they never open up again to see, and they just restore it and they say, oh, that worked. And I can see when the patient comes to me, the implant threads are exposed. It's a mess. It never worked. It shouldn't have been done in the first place because you're not understanding what you wanted to do. So sometimes I do ridge preservation with a socket augmentation. Sometimes I don't.
Let's quickly, just on that topic, I'll wrap it up because I've got 5-6 more case scenarios to go through. If you're going to graft the socket, what material? The sintered, so the cooked pure hydroxy apatite xenograft type material that's never going to resorb into the socket, or a fast resorbing synthetic material, or an allograft, or what material? So my debate would be, if you're going to be placing an implant pretty soon and you've gone and placed the entire socket full of a material that's never ever going to resorb, the majority of your implant might be in that non-resorbing material. Instead of letting it heal first and then dealing with that issue, like I showed you the first case that had a contour augmentation with the same material, that's my argument against not socket grafting, and also not costing the patient twice, not grafting twice. Brad?
Yeah, so the only time I would use a sintered xenograft material, which is actually something you showed me a few years ago, is if I have my implant entirely in bone, but I don't have enough volume and I want to do a contour augmentation and I want it to stay there. Fine. That is the only time I would use that material in a grafting. In a case like this, so for me in hierarchy, the first option is always, if I can do a socket shield, then it's a socket shield.
Preventative.
Nothing is going to compare to what you can get with a socket. I think Howard put up a nice case the other day on Instagram, whatever, where he showed two cases next to the other, one with a socket shield and one with grafting and connective tissue, and it still couldn't match it. Let's be clear about this. I know there are some naysayers still about socket shield. I've seen it. Nothing can give you what a socket shield can give you. Nothing. So that's your first choice. Second option, if you have a contained bony defect, but you need to put the implant in that bone, then that is where I would use either a synthetic, depending on the material now, or to a lesser extent, a collagenated graft material, or autogenous shavings.
Okay.
All
right, well, look, Brad, what I'm going to try and do is, because we've got about 5 or 6 more of these to get through, let's see if we can limit, like 2 minutes to each case. I'm going to jump to the next one, if that's okay with you. Yeah?
Yeah.
We covered socket grafting. Let's go on to one more. Here we go.
I'm giving you guys my opinion, just by the way, from my experience.
Yeah.
I'm not saying it's
okay. All right. Let's have a look. So we saw this one already. This was my case from earlier. The point that we made there, let's go back one. As Brad said, the majority of this implant is contained within the bony envelope, right? It's not relying on a graft for its primary stability. It's not relying on a graft at all for its osseointegration. You're basically giving the site a boob job. It's a contour augmentation purely to augment the facial. And yes, you want this most critical part of the implant to have stable hard tissue over the long term of a minimum of 2 millimeters, ideally 2 to 4. But in that case, you got a sintered xenograft contour augmentation. Let's look at these 3 terms that we're introducing very late in the webinar here. Osteogenic potential, graft stability, space maintenance. I tried to introduce these earlier, but osteogenic potential means where's the bone growth going to come from? If you just throw on the biomaterial here, let's talk about where is the bone growth going to come from. It's not coming from down there. It's coming from the bony peaks of the adjacent teeth. It's coming from the palatal bone and the bony peak on this adjacent tooth here. That's the osteogenic potential. Where's the stability coming from? It's partly maintained over the implant in this area over here. But this isn't a contained defect much. It's almost flat. In fact, you're packing a material onto a flat surface. So the stability is going to come from what is going to contain it, which is a membrane, right? And what is going to maintain the space, membrane, and the type of material you use. Let's have a look at this defect, right? Similar, if not same thing, but not, maybe worse. There's a nasal spine. The osteogenic potential is even less in this case, a little bit from here, a little bit from here, and almost nothing providing graft stability and space maintenance. Are you guys beginning to see why you can't just throw any material in any site and expect it to work? How is this site different? Can you see that there's some bony peaks here? That there's an extraction socket? Yes, there's a distance down the facial, but most of the defect is contained within bone. It's a contained bony defect, and it has a lot of osteogenic potential from all over, as well as space maintenance and graft stability. Okay, Brad, how about this case? Socket graft, yes or no?
If it's got all intact, no, I would just all place the implant well and then do it with it, implant placement.
Sure. Okay.
There's another point I just want to make, Jonathan, that I think is very important to bear in mind. You must remember when we augmenting for around the implant with bone, it's not just about augmentation in order to have volume. The bone behaves in a certain way as well. And remember, we get your different types of bone. They've classified whether you call it D1 or T or 1 to 4 from the density of bone. And the bone behaves differently with the densities. Like Frank Schwartzem are doing these techniques where they're taking the teeth and they're just cutting a piece of tooth and drilling it on to get volume and putting an implant in there. That is not going to be that's going to be like type 1 bone. And we know type 1 bone is like the second worst bone you can put an implant in, because bone is a living tissue and that tissue has to function. And I mean, Salo always speaks about it when he speaks about osteodensification of the denser burrs. There's a reason why he says using your allografts and not your xenografts, because those particular changes the behavior of the bone. So it's not just about creating volume of bone, it's also about creating a biologically bioactive bone that behaves in a certain way. And that is also influenced by the type of material we sometimes use.
Yeah. So arguably, if you went and put a sintered xenograft into this area, a couple of months later when you're planning for implant placement, all of that contained socket will still be that material, correct?
Yes. And even if that implant integrates, and let's say the patient is a Bruxer, you may find a year or two down the line, that implant will actually come out or lose if that bone, because that's a potential, because that bone's adaptive ability is influenced by the
Another way to look at it, Brad, is that the bone that the majority of the implant is supported by is not the quality of the patient's own residual bone. The volume of it is predominantly this hydroxyapatite that is not living bone, and minuscule amounts of endosteum, which is the inner lining of bone that has the immune cells, that has the ability to fight off peri-implantitis, inflammation, blah, 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 is woven tiny bits of it between those particles.
And that to me is not appreciated enough when you look at a lot of these cases and presentations and research.
Yeah. Okay, what about this case? Right, so this is a case, a practitioner who I know or knew was doing contour augmentations purely with a synthetic bone putty with no membrane. That is just a razor flap, squirt basically because it's injectable bone, place it onto the buccal area, put the flap back, and then place implants. What do we do here?
Are they integrated?
They're integrated. Stumped. I mean, the reason I was through this as a curveball, because I guarantee everyone watching this is seeing this in practice every single week.
I'd be grateful this is not the central incisors and just do a free graft.
Soft tissue, yeah. Depending on the amount of bone loss, obviously full assessment, check amounts, check the amount of bone loss. If it's active disease, peri-implantitis, that sort of thing, maybe the implants have to go, but maybe it can be salvaged with just a soft tissue graft and maintenance.
And with a soft tissue graft, I wouldn't even be trying to cover all that metal.
Yeah.
It
No, you're
just
just trying to augment this attached keratinized tissue onto the buccal. Because I think for those of you who don't recognize this, this is just mobile mucosa. And look, I mean, look at the plaque accumulation, and look at this. Anyway, this was a curveball to any of you looking at this thinking that you could just throw on a bone graft here. That's not going to work. That's not going to work. Okay, how about here? So this is post-placement. It looked like CBCT as though this implant had lost the crystal bone. The site was opened. What do we do here? What type of material? What can we do? Those of you who are watching, think of these factors. What's going to provide the graft stability? What's going to provide the space maintenance and the osteogenic potential? Do we use a bone block? Do we use a sintered xenograft? Do we use collagen membrane? Do we use a rigid membrane? We're trying to possibly augment a bit of bone onto the critical, coronal buccal area of this implant. I would argue a sintered xenograft would be adequate. A block could also work here, so an autogenous bone block, because you've got a bone peak there, you've got a bone peak there. You can build nice autogenous bone over this implant. That'll be healthy, the patient's own bone, full of bone-living cells. Alternatively, the majority of the implant is contained within residual bone, maybe a non-resorbing xenograft of this area. Either membrane could work. I'd probably opt for a resorbable, so I don't have to go in a third time. Anything to add, Brad?
I think the only thing I would also look at here is the vestibule. If you need to do a vestibuloplasty with this kind of, because that's going to aggravate the situation.
Sure. Okay. What Bradley means by that is the mucogingival junction running right onto the ridge? Meaning, does this patient need attached keratinized tissue that extends from there at least a couple of millimeters down onto the buccal so that there's a vestibular depth and attached keratinized tissue on the buccal? I think we're wrapping this up. Probably this is the second or the last case. This is a failed implant. Came out. The area was augmented with a calcium phosphosilicate synthetic bone putty that was injected into this defect, and the flap was placed back with no membrane. And this is, I think, 3 or 4 months later, the CBCT. Soft tissue had grown down there. This entire area looked exactly the same. I mean, the deepest part of it had filled with bone down there, but this defect looked exactly the same. So synthetic bone material in this instance, and we're not talking about the material that Dr. Bredekamp used in his lower anterior case. This is a calcium phosphosilicate putty without a membrane. That failed. Even though this is a contained defect, soft tissue grew right down there. And in my experience, I don't know, Brad, if you can add to it, that type of synthetic putty does not work well in these defects.
The only place I use that putty from my own experience is when I'm doing a socket shield and I want to fill the space between the root and the implant and other parts of the socket with a material that I can inject into there. That's the only place I really use it.
Osteodensification?
And I was about to say, maybe a type 1, well, not even type 1, maybe sometimes a type 2 osteodensification.
Okay.
I would use it.
Gotcha.
That's the
so look, really, as we wrap up this talk and the discussion, and we've gone quite a bit over time here, was really trying to introduce some fundamental principles to you guys as viewers, and then show some cases, because we really can't tackle the entire subject from A to Z, but show you some clinical cases, showing the different materials and scenarios and factors, and tie up some take-home messages for you. Each case, every patient, every scenario is absolutely specific and different, and each scenario has a different type of bone material and technique and everything involved, and that's indicated. Someone today from overseas invited me for a lecture, also on hard tissue management, and asked me the same question: what bone material do you use? And it was just mind-blowing that this person who should be educated asked me that, because every single case has got a different material, a different indication, different factors. Bone materials do not behave the same, and there's certainly no one size fits all. Each material, and arguably also the combinations, that is the bone or the substitute and the membrane and the stabilization and the biomodifier, they must be used correctly in the correct indications. And that's basically it. Yeah. Thank you, guys. We're done. Okay. Can I unshare now?
Yes.
Moderator?
Thank you. Thank you so much. I think that was
cool.
very informative, and it was good for all of us to see. And I think your take-home messages is kind of what the fundamentals of this lecture should be. We have no questions. I did ask if there's any questions, if people can please put in a questions tab. So if there is no further questions, I think we can go straight through to Dr. Duarte. Should we give it a minute or so?
Yep.
Dr. Duarte, do you have anything to add to the discussions between Dr. Bredekamp and Dr. Toit? Lots.
Actually, I'm in a very good position because after my colleagues to speak, I don't think I have nothing new to say, you know. It's just a very difficult position that they put me. Fantastic case, very open discussion. Was very nice to hear, and congratulations to both, because it's always important to learn different ways of solving cases. This is the most important message. There is not a gold rule. Each case is a case, and I agree with that. And sometimes a combination of techniques, but materials are the proper way of solving the cases. But most important in solving the cases is 25% of my practice now is to redo cases. And they are even more challenging to redo the cases because the patients come with bone loss, and there's always the difficulty of keep the implants, take it out the implants, redo the case again. There's a cost, there's a morbidity of the patient that we must consider also, is multifactorial, and it's difficult to decide what is the best option sometimes.
Thank you for that. We still have no questions, so I think we can go straight into your lecture, Doctor.
Okay.
Thank you.
Share screen. Janela aplicação.
So you just want to add maybe,
Okay,
Celeste, for those of you who are still staying, 50
Yeah.
plus of you, it's a shortish presentation by Dr. Duarte, correct?
Okay. I would like to thank you to Wright Millers and to Sarah Sorb, of course, for this opportunity for me to show my clinical cases, and congratulate also Dr. Jonathan Dutoit and also Dr. Bredekamp for their presentations. And for me, as an oral surgeon, it's very important to show my cases here. And of course, I will think you are now watching them in slideshow. Okay, now my practice is in oral and maxillofacial surgery and oral implantology. I've done my education in London, and now I'm based in Portugal, in the north of the country. And of course, there is also nice things to visit us, like the people, like the food, and mostly the wine. It's always good. Now, I'm here to speak about synthetic material that is produced by Curazan, that is the Cerasor. And I will show you some different combinations of techniques, but for me, the most important is to test the materials. It's what I do for the company. I split my time between the surgery, the research, and also the lectures. And I'm not a purely academic, I'm a clinician. And for me, I look with very skeptic eyes for the materials. It's my job. And I will tell you my feelings, and I will show you what we can do with this synthetic material. Of course, it's important to say that we are talking a biocompatible synthetic ceramic material with a phase purity of 99%, what is very, very important for the results that we see. We can have Cerasor in various ways of use. The granules, that are the typical ones, the paste, and now the foam that I will show to you also. From the granules, there are 4 different and possible combinations. In my practice, I mainly use the Cerasor M, because the granules have a polygonal shape. What is important for me, because when we compact the granules, there is always a way of granules they combine, and the intercommunicating multiporosity is very important, and we have micro, meso, and microporous at about 65% that allows the blood to go inside and to combine all these granules is very important. There are also different combinations like the classic, the plus, and perio with different degrees of absorption and also different degrees of radiopacity. Now, for these presentations are available in a variety of geometric shapes, as I told you before, and is important to say also that this biomaterial has excellent histocompatibility and no local or systemic toxicity. In Europe, the people are very, very aware about toxicity, and our clinical protocols are always changing because of this kind of situations. As I told you before, we can use it also in paste or as a foam. The granulate is the classical presentation. Everyone has some degree of experience using the granules in different clinical situations. Now, paste is very, very also useful because of viscosity of the material, and we can use it in different clinical situations. The maxillary sinus approach is one of the examples, and the quantity of biomaterial in one syringe is considerable, what means that is a huge quantity and that we can use it in these cases. And now the foam. The foam is reinforced with ceramic particles, what means that is harder, but is also flexible, and we can adapt it to our bone defect. Now, I bring to you some clinical situations where I tested the materials. Of course, after my previous colleagues, my life is even more difficult because it's difficult to bring you something new. As I told you, I always bring some literature to sustain my clinical cases, and this included teeth is important to realize that we use not burrs anymore. We use the piezo surgery device to cut the bone for a long time already. Now, this is our clinical case that was a referral for us. This impacted 4.3. The main concern of our colleague was to extract the tooth without damage the inferior alveolar nerve. And in the second stage, he wants to place implants in this fourth quadrant region. Now, my approach was a little bit a combination between all the techniques that we had. Of course, for all the bone reconstructions, we need a CBCT. We need to work in three-dimensional images to see well the quantity of bone available, the anatomical structures, and to plan well our reconstruction. As you can see here, the tooth is completely horizontal and very, very near the bone, the nerve, sorry. And our approach was, and as you can see here in the sagittal cuts, very, very low margin of error to us, with the risk of provoking paresthesia to the patient. Now, we decide to open the flap and to do with piezo surgery kind of osteotomy, a rectangular osteotomy. We remove the vestibular bone plate and we keep it. We didn't throw it away. We keep it in saline solution, and we went to see the impacted tooth. We remove the impacted tooth, we remove also the granulation tissue, and now you can see here one of the applications of our biomaterial in a paste kind of presentation. Because of its viscosity, it enters all the bone defects and give some total feeling of the defect. We use again the same autogenous bone plate that we cut it with a piezo, and it fits very, very well. We don't need to put pins, or we don't need to put anything. Just press it, and because it's a little bit soft, the biomaterial, it will adapt perfectly. Just stitch, and as you can see here, after 4 mounts, there's a complete integration between our biomaterial and the autogenous bone left. After that, we refill the case to our colleagues to place the implants. As a surgeon, I work in collaboration with several colleagues. Sometimes we do the implants, and sometimes we only do the bone grafts. Now, cystic pathology, very important. I brought some different cases because it's always topic to speak about implants, but when I told you that I tried to test the biomaterials, I tried to test them in completely different clinical situations to see their behavior, not only in the implant field. Pathology is something that I do a lot, and for me it's very important to test it also in this field. There are a very small number of publications reported in the literature, and I brought one of my cases. This is the literature basis that we talk, and this is one case similar to what our colleagues show. And this is a cyst in the symphysis area in a very young lady, 22 years old, and she came to our clinic to listen our opinion. As you can see there is involvement of the 3.1 and 4.1 cyst. The vestibular plate is already perforated with some degree of deformation because of the intra-cyst pressure. And in the sagittal cuts, you see the completely dimension of the cyst. The lower border of the mandible is intact. The vestibular plate is already perforated, and it was a little bit of a challenge to do this case. The 3D reconstruction, as you can see there, the central incisors, they were already compromised with some degree of mobility, and we explain well to our patients that she will lose the teeth, and we will try to do the bone reconstruction, and maybe at the same time to place the implants. Now, this is the clinical presentation, and this is the first challenge: how to explain to a young patient that the situation is even more difficult than what she see in the mirror, because for her there's only 2 or 3 millimeters of gingiva that is missing. With the help of imagology, we will say to the patient, okay, it's not only 2 or 3 millimeters of soft tissue, we have a bone defect also. And when we raise the flap, it's immediately obvious that we will have a challenge in front of us. Now, we try to be very conservative regarding the autogenous bone that we will preserve. And in this particular case, we saw space for place our implants because of the lower border of the mandible with some degree of primer stability. We managed to place 2.9 implants with good primer stability. As you can see there in the lower border, the amount of microvascularity is not big, but gave us a little bit of intra-lesional blood. And we decide in the same surgical time to fulfill all the space between the bone and the implants with granulus, with Ceresorb M, and with a small membrane in the vestibular area. Is this to avoid and prevent the interference of soft tissue in our biomaterial? We stitch and we put the patient with the provisional, 2 provisional crowns, adhesive, And here it is, the situation before surgery and the situation after surgery. Now, this is a very interesting X-ray, because in the middle you see the X-ray with 4 months after surgery, and we can perfectly see well the autogenous bone in the bottom of the implants, and this is a second layer, that is the bone that we place that is in contact with the autogenous bone, and because the microvascularity is higher, there is some degree of density, and on top of the cervical part of the implant, the density of the biomaterial is not so good. But with time going by, and in 12 months, you can see already that all the body of the implant with biomaterial is almost compact, and we didn't lost in the cervical area of the implant, we didn't lost bone. And this is very important, not only to put biomaterial in our bone defects, but keep that biomaterial with some degree of previsibility. Now, maxillary bone graft, another example. This is a very strange case that we received. Young engineering that put 2 cemented crowns into these 2 teeth, 2 central incisors, and she came us because of the 2.1. I think there was a lack of communication between her dentist or her orthodontist and herself, because they sell to her a crown, a static crown with pink porcelain and some kind of aesthetic reconstruction. And I said to the patient, there's no way of keeping this crown. We must give a step back to come forward, because sometimes we must say to the patient that we don't agree with the treatment. We respect the treatment, but we don't agree with the treatment. And I decided to explain to her that I should extract the tooth and start by the bone reconstruction. And it was one of the cases that I stretched the biomaterial, because it's not easy to work in a central incisor, as you know, and don't promise it to the patient nothing apart from your work, because it's difficult to understand to the patient that after she spent some amount of money in two central incisors, porcelain crowns, I will redo the treatment. But the truth is, she agreed, and we decided to extract the tooth. And in the same surgical time, we put some biomaterial, some Seversort M, and as you can see there is blood between the polygonal granulars of the biomaterial, what is good. And of course, we put a resorbable membrane fixed with resorbable pins that I like, because I don't need to go again and to remove the pins. And the patient came out of the clinic with a removable prosthesis. That is something that we don't like. The patient also didn't like, but was the only option for her. And of course, we monitoring very well these patients, because, as you know, working with bone grafts, working with bone, sometimes we have fantastic follow-ups, and sometimes we don't have so good follow-ups. And for us, the rule is a very good follow-up of our patients, trying to control each patient from each 3 days after surgery, if the patient is not from far away. And here it is after 4 months. A very good bone contour, soft tissue cover of the defect. As you can see there, the line of bone is almost similar to the other, the 1.1. And we can say that, of course, but now we need to open it, to raise the flap, to see the bone density, and if there is good bone. In the past, there was an idea that after you place the biomaterial, and when you want to place one implant, the density of the bone is not so good, what means that the implant will not stay with primer stability. With this biomaterial, with Ceresorb M, I have a different idea, because every time that I do this type of reconstruction, and when I see the bone again and reopening, the bone density is good. We place the implant, we control the implant, 4 months of osseointegration and the reconstruction. Now, it's important to say that sometimes we need 2 steps to finish our cases, and we come 1 step down and to level the patient's expectations, and also to give space for us to achieve a good result. And here it is, the final X-ray. Now, mandibular bone graft. As I told you before, we work a lot with piezo surgery. We don't use burrs to cut autogenous bone. We don't believe on that. We believe in very physiological, histological cuts, because the degree of resorption is less with time. We do a very good follow-up of our patients. We like that. And we work with piezo for the last 20 years almost now. And a very singular clinical case. And I like these cases because these are the cases that allow me to test my materials and to know if they work and if they work properly in these kinds of cases. This is a considerable 3rd quadrant cyst with curiously, without any degree of complaints from the patient. She was a 44 lady that came to us because she felt some degree of pain in the 3rd quadrant, and general dentist thought about the wisdom tooth and take OPG, and she came to us with this clinical situation. Of course, we asked for a CBCT and to see the degree of expansion. As you can see here, there is a lot of expansion, interluminal pressure in the cyst, with some concerns in terms of maintenance of the lower border of the mandible. There was a risk of angle fracture, of course. There was a risk also of paresthesia. The patient, she was aware of all the complications that we could have in this surgery. We performed this surgery under general anesthesia because we have it in the clinical and it's safer in these kind of situations. And as you can see here in the surgical cuts, she has a fantastic luck because with the interluminal pressure of the cyst, the mandibular nerve was pressure to the lower border of the mandible, and she has the perception completely intact. Now, our plan to this patient was to, as you can see here, from the clinical point of view, it's not so perceptible, this pathology, and there was no swelling, there was no drainage of pus. It was it's a normal situation. Okay, we decide to, as I told you, to open with piezo, to be minimally invasive, if we can say that in this degree of clinical situation. We remove the bone plate, we extract the wisdom tooth that was impacted. Fortunately, all the capsule of the cyst came with the wisdom tooth. We clean very well the locum. And here we mix a little bit our reconstruction technique because there was a massive space to fulfill. We couldn't use autogenous bone. We decided to use a synthetic biomaterial, Ceresorb, and we combine it with a fibrin protocol. As you know, we can with the fibrin we can have basically three ways of applying it, with a sticky bone where we combine the biomaterial with the fibrin, the membranes, and also the fibrin glue. That is very important to allow attachment between our sticky bone and autogenous bone. Okay, we done the sticky bone, and before we done the sticky bone, we place some Cerosorb M. First of all, to allow the nerve to have some space and not so much compression. That is sometimes is our mistake when we do this kind of big reconstructions. The sticky bone was massive, and we try to fulfill all the space. And on the top of that, we also put a membrane. And as you can see here, we stitch very well. And this was our first immediate after surgery OPG. There was the endodontic treatment in the 3.6, and we extract the 3.8. As you can see here, we follow our patients, and after 1 year, this is the result that I present to you. There is no dysesthesia, no paresthesia. There was some degree of reconstruction, but you can see how different it is when you see in the 2D image and when you see in the 3D image, because the result is good, but it's not all this. Okay, this is the OPG to impress, but when we go in the 3D, you will see that it's not really compact bone. Okay, with time, you will have a better result, but this is the true image. And as you can see there is a lot of scaffold for bone to grow. Okay, because we also put the fibrin to stimulate the bone growing. And when we go here, you can see there is some spaces, even with all this degree of reconstruction. Anyway, in the sagittal cut, there are areas with good bone density already, and I call your attention for the images in the right corner, where you can see the infraorbital nerve intact and protected by the Cerosorb foam. That is a very good option to this kind of cases. 3D reconstruction of the bone, a good bone density, and the case sorted. We published this case in several papers in different approaches, in the Dental Tribune, in Implants, the International Magazine of Oral Implantology, and also in the Journal of Surgery, Periodontology, and Implant Research. Very recent papers from 2020. Some of these cases. Now, moving on to my two topics, trying to follow my time, not crossing too much. The maxillary sinus is always a very hot topic. As you know, it's difficult to place implant in the posterior maxilla because the bone is of poor quality, and also because there's the quantity is not too much available. This technique was already described by Tantum in 1977. Initially, the access was through the alveolar crest, and in 80, Boyne and James introduced the concept of lateral osteotomy that we follow. It was modified by Cadwell Luke, and Interella in 1998 advised that the maxillary bone window be ultrasound to maintain the Schneiderian membrane. And here we can see the different approaches, the internal approaches with osteotomos, that there are some colleagues that advise this case. Of course, the diagram is not perfect, because when you have this amount of bone, maybe you will place the implant straight away, but this is always an option. It requires some degree of gentleness to place the osteotomes, to handle the osteotomes, and to place your implant. And of course, the external approach, where we do an external window with piezo. We try to keep the Schneiderian membrane intact, and we fulfill all the space and place implants in the second stage. Or if you have 5 millimeters of bone available, you can place the implants in the same surgical time. Now, here the major works are from Professor Tommaso Versellotti, that one of the creators of the piezo surgery device. Is very interesting, the figures that he shows with the elevation of the piezo, the Schneiderian membrane can be intact without perforation in 95% of success rate, what is very, very important. Of course, the time that we use to do this technique for me is not the most important issue. I prefer to do it well, with time, with consideration to all the anatomic structures. One thing is sure, if you keep the membrane intact, your results potentially are better. Nevertheless, I brought you one case that I didn't manage to keep the integrity of the membrane, and I done it perforation, and how I solve it, because I think it's very important to share not only the good cases but also the complications, because I learn a lot with complications in the daily basis. It's very important to identify the complication and solve it in the same surgery. This is a case that was referral for our clinic. The problem with this case was that our colleague placed the implant twice and he failed twice, and I asked for a CBCT, and as you can see there, in the mesial root of the molar there is a dental cyst. That was the main reason why the implant was failing continuously. Now, I said to my colleague, okay, we need to take the implant out, we need to try to extract the tooth also. Please try to do that before you send me the case. And she done that. And when I received the patient was in this kind of situation. Okay, and our protocol is to raise a full thickness flap and with a piezo surgery device to do a lateral window to place our bone graft. As you can see in the middle image from the bottom, we done the perforation, or as according to the literature, 32%, 33% are already perforated also. What we do, we create a new Schneiderian membrane, and for that we place one membrane, hose guide in this case, is also resorbable membrane, okay? Because if not, we are putting biomaterial to the posterior all of the maxillary sinus, and we will not place implants there. It's important to control where we place our biomaterial, where we place our bone graft. We need to place and keep our bone graft where we need it. Now, as you can see there, we place another membrane and we place our biomaterial Ceresorb M in granulus, and this is a compact graft, and we wait a little bit for the bone, for the blood, sorry. And as you can see there is already one relation between the biomaterial and the bone that is very useful. It is important, so important, the porosity. And we cut the membrane, the hose guide membrane, because it's a good membrane in terms of size, and we just cut it in the middle, and we can use it to do a new Schneiderian membrane, and the rest of the membrane we use it for the vestibular cover of our bone graft. We wait for 4 months and we are ready to place the implant. As you can see there, good density bone, we place our implant, a good primer stability, and also the bone and the implant in the crown. Of course, it was important to place 2 implants, but the patient didn't have enough money for that. But nevertheless, the bone is there. If we decide to, in the future, to place another implant, we can use it, the same bone graft. Okay. Now, normal that ask the question, okay, if I want to do a bone graft from the maxillary sinus and place the implant, what are the indications, what I need? Of course, according to the literature, you need at least 5 millimeters, and this 5 millimeters will give you the primary stability in the cervical part of the implant to keep it there. In these situations, the correct planning and very careful execution of the surgical technique are crucial to achieve primary implant stability, and is the key factor for osseointegration. Of course, the great advantage in this approach is a single surgical stage. We reduce the treatment time, the cost, the lower mobility for the patient, because we don't need, and we avoid a second intervention. According to the most authors, what is important is not the amount of residual bone, but the primary stability of the implant that is achieved during its insertion. Now, a case from the maxillary sinus, a bone graft for the maxillary sinus, and in the second quadrant in that implant. We are talking about 2.5, 2.6. In 2.5 area, we have some degree of bone. In the 2.6, the challenge was bigger. And 3D bone reconstruction, of course, CBCT. Our colleague already tried to put some degree of biomaterial, and the problem is when you keep changing biomaterials, you don't explore the biomaterial, and if you look only for the cost, you will have a learning curve in all the biomaterials, and you never have optimization of your resources. Is why I always say there are very good biomaterials in the market. Of course, I work with Kurasan, with Cerasort, but there are also very good biomaterials in other biomaterials good in the market. The important is to optimize our learning curve and to know how to achieve good results in very long-term basis. That is the most important. Now, returning to our clinical case, very different views from the CBCT. And as you can see there was no enough bone to place our one or two implants. And here it is our technique, and is why I like step by step what I like to do. Now, as I told you before, we perform lateral window with the piezo surgery. We try to keep when we move the bone window to the interior, we try to keep the integrity of the Schneiderian membrane if possible. In this case was possible. We do 2 osteotomies in the alveolar bone of the place of the implants, and we use the implant indicator just to keep the bone window in place. And now we're using sticky bone and trying to maximize the combination of sticky bone. We do a good amount of sticky bone and membranes also. What we start to do, for me, is very, very important to have bone surrounding all the implant, and bone in the quantity and in placement they can control. And it's because of that I reconstruct the internal hole of my bone graft. I start by putting a little bit of bone in the internal area. I compact this internal bone, as you can see there. I place my implants, and on top of them, I place another amount of biomaterial combined with fibrin. I know that I have bone, implants, and bone. Okay, the implants are surrounded by bone. I use the fibrin glue to homogenize all my graft, and the membranes to prevent soft tissue interference with my bone graft. I stitch very well, and as you can see here, the result, we have 2 implants surrounded by bone. And our control, very important. And you can see the autogenous bone on of the apical part of our implants is very important because it's my apical limit. I know that my implants will keep also in bone. And here are some images about the prosthodontic reconstruction. And here it is, the crowns in place, ceramic crowns in place, and final result of this. Okay, from the beginning until the end. Final topic, I brought totally dentaless patients because it's always a challenge to have enough bone to reconstruct this. And the classification from Janssen, who advised us to place 4 implants and all 4 in the immediate function. I'm not going into details on this. Of course, it's very nice. It's about also zygomatic implants. That is one field that I work a lot. In this kind of things, in this type of rehabilitation. But as you can see here in your right bottom, there is some degree of bone resorption, and there are patterns of bone resorption in terms of total dentaless patients, and we know that not only in the maxilla but also in the mandible is a difficult topic. Also, very nice topic, and I brought you a very young lady that came to us. I didn't done the maxilla. The upper jaw was done by other colleague. That referral for us, the mandible case. The mandible case was a periodontal case with some roots to extract, but the problem was the quantity of bone available to place implants. As you can see here, it seems that the case is not so bad, but when we go to the sagittal cut, some degree of periapical also lesions. There was teeth movement in some of the central and lateral incisors. It was a complex case, and that we decide according to the patient, and it was also the previous idea of the patient to have the same treatment that he has in the upper jaw. But here is my challenge. When we go to the anterior area of the mandible, the bone was very, very thin. And I knew from the beginning, after I extract the teeth, I will have problems in placing my implants. Even if we are talking about 3 millimeters implants, the bone will be like a knife, not very large, and it will be a challenge for me. 3D reconstruction aspect of the patient. This is our protocol to all the patients. This is our clinical situation with a lot of caries, as I told you, roots, decay, teeth. Okay, now we decide to extract the teeth. Of course, we raise the flap, trying to avoid our preserve the bone the most that we can. We use surgical guides for this. We study very well our dentalist patients. We use again, as you can see here, we use the piezo surgery to do a platform because we feel after all 20 years of follow-up that we cut this bone with burrs in a long-term basis, it will resorb more. With the piezo is a more physiological cut. We create a platform to place our implants. Nevertheless, there was implant exposure in the vestibular area. Of course, we know that primer stability was achieved, but we cannot close our eyes and say that, okay, everything is perfect. No, it's not perfect. We need to do bone reconstruction, and we done it in the same surgical time. This is on another application of our biomaterial in combination with the implants placement in total dentals. And here it is, a challenge for the biomaterial, because we are talking in horizontal and vertical reconstruction. In this case, a good amount of bone. We place we place some membranes, and also we put on top of these fibrin membranes, we put hose guide membrane fixed with resolvable pins from Kurzan that are the Union tags. We stitch it very, very well, and here it is, the final result. We leave it the molar for now because we are waiting for the osteointegration of the implant, and it's important to see the post-op CBCT with the bone reconstruction. It's important to follow these patients very well. And for me, the CBCT is the proof of truth, because sometimes we feel that we've done a fantastic surgery and we go to the CBCT is a lesson, because it always shows that we can improve here and we can improve there. Okay, and bone reconstruction is a coadjuvant of your results. And here it is, the surgical cut. As you can see, they are very thin bone in all the mandible, and we managed to place our implants according to that. From time to time we do also a crest expansion, but on this case was very, very difficult to do that. The 3D reconstruction already with the bone graft of our patients. Okay, and now we leave it with a message. The future belongs to them that believe in the beauty of their dreams. And I invite you to come to Porto, the land of the wine and one of the most European top football clubs. And of course, we have also the food and the people to receive you in our country, in my city. Okay.
Thank you so much, Dr. Duarte. We really, really appreciate your time. Is there anyone with questions? Please put your questions in the question tab. I don't know if Dr. Bredekamp or Dr. Jonathan du Toit still has anything to say or to add.
Well, it's, usually if there's no questions, one of two things happen. Either the topic was overwhelming or it was terribly boring. Let's hope it was neither of those.
I apologize for my part of boring.
We've got someone typing, Dr. Aloma here. So let's see what's coming up. Well, everybody is still logged on, so I doubt that it was boring. Dr. Aloma here, thank you so much. He says, thank you very much. It was neither boring nor overwhelming.
Thank you.
Thank you.
Okay, well, if there's no other questions, I want to thank all of you, and for everybody that spends their evening trying to educate themselves more. That should always be something we all strive for. And I want to thank Dr. Bredekamp, Dr. du Toit, and Duarte for your time. We really, really appreciate it. Dr. Michael Opperman says, excellent. Dr. Timothy Struvik says, awesome lecture. Thank you. And Lynette says, thank you so much for an informative session. So thank you all very much.
Thank you. It was a pleasure.
Okay.
Have a good night.
Thank you.
Have a good evening, everybody.
Well, to see you soon.
Thanks. Bye-bye.
Bye.